Hello and welcome to the Ask a Nurse webinar. I'm Nurse Linda. Oh, and I need to describe myself. I forgot to last time, so I apologize for that. I am a lightly pigmented woman with brown hair that looks much browner on the video, has silver in it, not gray, silver. And I wear glasses just for reading, so I always have them on in the videos. And just welcome to everyone. It's a crazy kind of day today because we're all waiting for this hurricane to go over Florida. It's already hit some of the island nations around Florida and left a lot of destruction and lots of issues for people. So let's keep those people in mind, and hopefully that we will have no deaths from this. People are very well prepared, and so, hopefully everything will go just fine. It did make me think about friends in our community and what a rough time they may be having because of the hurricane and all the after effects that's going to come after that with the flooding and the down lines and all that. I hope that most people were able to get out. I know not everybody, it's that easy that they can pack up and leave. And if you're on mechanical ventilation or you plugging a wheelchair into the wall, that leaves you without your critical needed resources. So I hope everybody has an emergency plan, that they've notified the proper utilities and paramedics, EMTs in their area, that they have some special needs, if it's spinal cord injury, brain injury, whatever healthcare concern that you might have, so that emergency personnel can be aware of what's going on in your home. You can notify them ahead of time so that they keep a file, and so they know when that address calls in with an emergency call, they'll know that there's special issues that go on there. I did that for my husband, who had spinal cord injury, but from a disease process. And so he had a lot of oral motor problems. So when he would have to call, they sometimes were not very nice, because it would sound like he'd been drinking, or, maybe that he was up to some kind of something or other. And so we notified them that there was this issue, and that took care of the problem immediately. And they would just, okay, we're sending a car right now. And so it just, he didn't even really have to communicate much with them. So it really helped out a lot. But anyway, another thing I was thinking about, we had some severe flooding here where I live, and some people were on TV and they had their emergency plan. They got to the shelter, they were safe, but once they got to the shelter, they were all thinking, now what? I don't have a home I can go back to. It's not safe to get back to my home. Now what do I do? So in your emergency plan, be sure and include for after you reach safety, after the event is over. And if you can't go back to your home, do you have a place where you can go? Do you have a place where, equipment can become available for you? Or, how is all that going to work if you can't go back to your home setting? So just some important things to be aware about. Also, if there's an emergency situation, like where, where you have to go to a shelter or something, and you maybe have to spend the night or a great length of time. Sometimes if you have listed yourself on the with the EMTs, they might find like a healthcare facility to take you where there's a hospital bed and equipment that you might be needing if you're going to be a prolonged period at some kind of a shelter type of environment. So there's all kinds of resources that are available out there for people, but most people don't know about it until it's time, of course, to use them. So today, we're getting near the end of September, so we're ending Spinal Cord Injury Awareness Month. And so I was thinking about the blogs this past month, and I think most people that read the blogs already have some kind of nervous system issue. So I kind of wrote some reminders for just, kind of getting through the process, things to help with bowels, things to help with your bladder management, that kind of thing. And, it pertains to spinal cord injury, but many people with head injury and stroke also have the same neurological outcomes. And so this might be useful in your circumstance as well. So I try to include people who have brain injury in those as well. So don't just think, oh, this is for spinal cord, I don't need to read this today. Just if you're interested in that topic, that's a helpful thing to do. So today is all about bowels. And somebody asked last month, can we have a day all about bowels? And of course we can. And so we're having that day today. But if you have any questions about anything, please be sure to write into the webpage, and I can answer those questions for you as well. So let's talk about bowels. And there are basically 4 things that occur that you need to watch. Now there are 4 things. So I put it down into a small number of things, but within each subsection, there's a number of things to watch. So with bowels, you need to think about your intake. What you're putting in is going to come out. So you need to think about what's going in there. So monitoring your fluid intake, being sure you get enough fluid. That can be a challenge if you're on a bladder management program. Looking at the types of food that you eat. Chewing, looking at how well you can chew your food, because digestion begins in your mouth. When you're chewing your food and breaking it down and saliva is mixing with it, that's breaking your food down, making it easier to digest. So by the time it gets to your stomach, it's already started the digestion process. So if you have problems in your mouth, some oral problems, be mindful of your oral hygiene. Look at your chewing and your ability to do those kind of things. Make sure your dentition, your dental care is up to date. Looking at medications that constipate, that cause diarrhea, any over-the-counter substances that you're taking, any complementary, alternative, recreational drugs, they all interact together. And so you might be taking something that doesn't really affect bowel function that much, but it's going to go, the drug's going to go through your bowel, it's going to be absorbed through there or through your liver. So look at that drug, look at the drugs that you're taking that are prescribed, because maybe separately they don't affect the bowels too much, but maybe they work together and all of a sudden they do. So always report every medication that you're taking orally, rectally, rubbing on your skin, inhaling, putting eye drops in your eyes, anything that you're putting anywhere into or on the surface of your body. Be sure and report those things and to your physician or your healthcare professional. They'll enter it in the computer, and the computer will tell if there's any contraindications for doing that sort of thing. So always be sure and check with your healthcare professional. That's the safe way to be with that. Again, looking at what's going in, looking at your alcohol intake, sugar intake, salt intake, all these things affect your bowel function. So, being mindful of those sort of things. The second thing to look at is processing, how the bowels work. So some bowels are slower, some are faster after neurological injury. And as I say, that can be from spinal cord injury. Everybody thinks, oh, neurogenic bowel, which is a problem with the nerves, not constipation, not diarrhea. It's a nerve problem, so it has to be treated with a bowel program. It occurs in about 68 to 70% of people who have head injury as well. The location of where the injury is may be different. It may be in the brain and not in the spinal cord, but it still affects the nerves. And so neurogenic bowel is a diagnosis that is made. It must be treated with a bowel program. A lot of times people say, oh, I'm really constipated. I don't have a bowel movement because I'm constipated. You may be constipated, and you can be constipated, but in the case of neurogenic bowel, it's a problem with the nerves. So treating constipation is not going to treat the neurogenic bowel issue. So you have to be very careful about that. Some people, as I said, some people's bowel will work faster, some people's bowel will work slower. It's just the way human beings are made. We're all different. You can have a twin exactly genetically identical to you. You could be in some kind of accident or have a disease, have a neurogenic bowel for some reason, and ones will work differently than the other ones work. So you can't really ever compare yourself to what somebody else is doing and how that's working. Well, if somebody else is doing this, will this work for me? It's really very individual for each person. And that can be a challenge in treating neurogenic bowel because people react differently to whatever treatments are going on. So there's a lot of trial and error in treating neurogenic bowel. We have a basic pattern that we give everybody, you know, about how to evacuate their bowel if they have a higher level injury with a reflexive or spastic bowel, or if they have a lower level injury that the bowel is flaccid or doesn't respond to stimulation. And so we have outlines of these programs, but everybody needs a little tweak here, a little tweak there. So it can become quite a complicated process. You can check the speed of your bowel, which is like your blood pressure. It varies at different times of the day. It varies from one point in the day to another point in the day. So you can check how well your bowel functions. It's called transit time. And this will tell you how long it takes food to move from your mouth to being excreted. So what you do is don't eat corn for a little while. Says you want that to clear out of your system if you've eaten it before. But find a time when you haven't eaten corn for a while, or stop eating just corn, and then have corn at one meal. Note the day and time when you have the corn. Write it down on a piece of paper so you don't have to, wait a minute, when was that? Just write it down on a piece of paper. And then, or take a picture on your phone of your corn on your plate, because the timestamp will be on that picture. Okay, then don't eat corn anymore until you see it in your stool. Now, the time from when you ate the corn till the time that you saw it in your stool is your transit time. So transit time can range between 12 and 24 hours, 48 hours for some people. It's like, what is the normal? Well, it's like a day or two is normal. But what is normal? Well, even in the population that doesn't have neurological injury, there's a huge variation. Some people's transit time is like 10 hours. Some people's transit time is like 100 hours. So there's just a lot of variability in it. But you'll be able to get your general transit time by doing that. Now, there are transit tests that you can go, and your healthcare provider can order it. It's very laborious. It's a lot of x-rays and dyes. Sometimes they give you a pill to swallow. If your healthcare professional wants you to have that test, be sure and have it, because they're looking for very specific kinds of things in those tests. But if you just want to know how swiftly your bowel works, there's a good test. You can do it at home. It's not going to cause any problems if you can eat corn. Now, if you can't eat corn, then you might want to try other substance that don't, corn has that shell on it, doesn't digest very well. So a lot of times people see corn out the other way. So that's a good way to do that. So, but your transit time will vary even within your own self. So if you're eating foods that are very constipating, that's going to slow your transit time. If you're eating a lot of processed foods, if you're diabetic and you eat a lot of carbohydrates, that speeds up your transit time. If you eat a lot of greasy foods, that's going to speed up your transit time. You don't want a full diet of any of those kind of things, but transit time does have some variation. And it also, transit time works with your emotions. So your mental well-being is very important to the transit time. So if you have depression, or you have anxiety, or you have some kind of change in your mental well-being, and people do, we have ups and downs. Sometimes people have chronic issues. Sometimes people have a happy day. Sometimes they have just a kind of day. So that can affect your transit time. Another thing that can affect your transit time is if you get anxious about something, or if there's something that's going on that's kind of getting you either slowed down or hepped up in your mental wellness. So I think of like, you've got an exam at school. Somebody wrote this article about they were going to meet their fiance's parents for the first time, and wouldn't you know it, on the way they have a bowel accident in the car. Of course, because this was a time, it was kind of a high anxiety time, you know, oh, I'm going to meet my spouse's parent, my future spouse's parents for the first time. You know, you can imagine that brings a lot up in people's emotions. So it can be happy times, it can be sad times that affect your emotional status. And so that can affect your transit time. And it comes at the least opportune time, like this guy in his car. So anyway, there are changes to your transit time, but you can kind of get a general feel for how your transit time is working out. And then there's the elimination phase. And so we don't recommend that people use enemas. We don't recommend that people use laxatives, but those words are used differently in different ways in healthcare. So as I mentioned, there's the standardized protocol for your bowel program. You use a cathartic if you have a reflexive bowel with digital stimulation. You use manual evacuation if you have the areflexive bowel. Now, people will do things a little differently. They'll add maybe a laxative, not a laxative that you take that's going to result in a bowel movement, because those are too unpredictable and you will be incontinent, and they work after the initial elimination. They continue to work and there'll be more, so they're kind of a mess. But there are some laxatives that people take. Now, we used to tell everybody take a fiber laxative. That's like Metamucil, Citracil. There are several other varieties, Equate. We used to tell everybody we used to put everybody on that because that added bulk to the stool and it moved things along. But what people were finding from people like me, blabbermouths like me, was that people didn't take the water. There's a water amount that you have to take with those fiber laxatives, the Metamucils. And if you don't take that, that just becomes a rock in the bowel and it becomes impossible to move. So you get impaction, you get a lot of problems. It's very difficult. The bowel program is prolonged. So now the current recommendations, the guidelines for bowel programs, is not to put everybody on that. If you're on one of those products and it's working well, just move on with your life and say, good for me. If you're on one of those products and you're having a really slow bowel program and you're finding you're not able to drink the 6 to 8 ounces of water at a time with those fiber laxative, I've seen people divided up in the day so that they'll take a little bit of, they get their 150 cc's because they're on a bowel management program. So they get their 150 cc's of fluid every hour. And they're putting a little bit of the fiber laxative in with the first 150 and a little bit with a little bit more until they get the whole thing down. That is really heroic measures. It might not necessarily be the thing for you, but don't just stop it, because if your bowels become accustomed to it, you want to talk to your healthcare professional to see if you can stop it or if you need to wean off of it. Because if your bowels become accustomed to it, you're going to need to wean off of it. If you just stop it, you're going to get constipated very quickly. So talk to your healthcare provider. Always, I speak in generalities. Always discuss with your healthcare provider what is the right thing for the unique being that is you. So find out about that. Now, there are other things that people take that are called laxatives, like Senna. Colace is not necessarily a laxative, but it adds some coating onto the stool, which helps push it through. Some people take this laxative called Miralax, but it works differently than those that flush out the bowel. It draws fluid into the bowel to keep it moist, to help it expel more easily. So there are a lot of things that people add. Now, I see people all the time. Sometimes I look at somebody's medication list and they're on things for medications for diarrhea, and they're on medications for constipation. And why are you on medications that are, working against each other in the bowel? Oh, because if I'm not on the one, I have diarrhea. If I'm not on the other one, I have constipation, but they're working against each other. So a lot of times in my own practice, we'll just take people off those medications altogether to see what happens. That doesn't mean that you should stop yours right away. It's because, we know more about that individual patient and we're able to do that sometimes. Sometimes you have to kind of titrate or wean off of those. So that elimination process, getting the stool out, is just one piece of the puzzle. And the fourth piece of the puzzle is movement. So adding movement to your body. People who can walk, that are walking around, they're moving their legs, stretching their muscles. Those muscles on the legs are connected to the abdominal muscles. They're pulling those abdominal muscles. As you move around, as you twist and turn, even if you're doing your pressure releases, it's affecting your bowel because you're moving your body. So anything you can do to move your body, and it can be like if you have functional electrical stimulation for your legs, that's a great movement because those muscles are being engaged, and that is also affecting the muscles in your abdomen. So people tend to have easier, faster bowel movements, more predictable if they're doing that. But you don't have to have one of those. You can do passive range of motion. If you can't move your legs yourself, have somebody else move them. Moving your body is one of the most important things you can do, because even though you have a spinal cord injury or a brain injury, that part of your body, those muscles that are affected, those nerves that are affected, are craving movement. They're looking for movement. Your body is made to move. So why aren't you moving? And the communication can't get through. Well, I'm not moving because we have this nerve communication problem somewhere in the brain or spinal cord. Those messages can't get through. So you need to provide the movement from the outside. So anything you can do, especially to the lower body. Now for general health, your upper body as well, but for your bowel, your lower body as well. Those are all going to be keenly important things to work on. So a lot of people, now there are some people, and this is kind of ironic, there are some people that get put on a bowel program in the rehabilitation facility, and it works, and they never change it, and they don't do anything different, and it just works. Now, for those people whose bowel program doesn't go that smoothly, it's like, wait a minute, how could that possibly be? But it is, and nobody knows why, but it just is. It probably has a lot to do with the autonomic nervous system that's controlling that bowel function and how well it's doing, and who has how much issues you have with your autonomic nervous system is kind of unknown. People who have higher level spinal cord injury generally have more issues with their autonomic nervous system, but people who have lower level injuries sometimes have difficulty with the autonomic nervous system as well. So there is a test that can test your autonomic nervous system, but you don't want to ask for it. It's hugely invasive. It's very complicated. The risk of doing it are high. So doctors never recommend it because it's not for your average person. It's only like for very, very specialized types of things, because the risks are so much greater than the benefits than what you find out. So, you can kind of tell if you have a lot of AD, you probably have a lot more problems with your autonomic nervous system. If you have a lot of infections, probably from the autonomic nervous system. If you have more skin breakdown, it can be autonomic, but that would be more from pressure. So we can't really gauge on that one. But if you have a more difficult bowel program, that can be the autonomic nervous system. So it's not really anything you're doing. It's just the way your body works now. So there are some issues to think about. Some people, just freak out at the thought of a bowel program. And I tell you, if I had never heard of one, and I had just been through some kind of disease process that's affected my bowels now, or some kind of accident that has harmed my brain or spinal cord, and somebody walks in and says, well, I'm going to teach you how to empty your bowels, and you have to use your finger, and it's like, wait a minute, now what? I have never met a patient that was like, oh goody, I've heard all about this and I can't wait to do it. It always comes as a shock to people. We don't see bowel programs on TV, health medical shows where everybody gets cured in the 60-minute episode. So it's not one of those things that's readily talked about. And you know what? You don't have to talk about it. Some people are so embarrassed about their bowel program. And, you know, who needs to know but you and your healthcare professional? Maybe if you have a caregiver, that might be a person who, you know, is doing the bowel program. But, you know, not everything needs to be discussed openly in public about what's going on. So if you don't want people to know that you have a bowel program, you don't need to let them know what you're doing. Just, you know, you can keep that part of your life private. It's okay. So anyway, you do your bowel program, and it's a huge hurdle to get over that initial shock of the bowel program. And, you know, some people will put on like, 4 pairs of gloves, and they'll just be like, oh, no, I'm not going to do that. And, you know, but now it's become your new normal. This is now your normal for you. Maybe not for long with all the progress that's going on in spinal cord injury right now, and brain injury and neurological repair and different things that are going on. But right now it's the way it's done. So we have to live in reality of now. But because people are so, I guess, freaked out about doing their bowel program, they want to get in and get out real fast. So they want to do that. They want to put that suppository in, and then they want to do the digital stim, and they do it real fast. And if you have that higher level injury and you have that reflexive bowel, people who have the reflexive bowel, it's reflexive because it has tone, which is our new word for spasticity. So if you have tone in your body, what we see on the outside is usually on the inside. You have spasms in your body, your bowel is probably spastic too. So if you go in there doing that digital stim as fast as you can do it, you are increasing that tone or spasticity in your bowel. It's going to take more time for the bowel program to work because you're closing the internal sphincter. At your rectum, you have 2 sphincters you have to think about. The external one will open automatically when stool is there. The internal one is the one you're going for. So you have to use a well-lubricated, gloved finger. And, you know, sometimes I see people that put a drop of lubricant right there and it'll spread out as it goes in. No, that's not enough. Put some lubricant on there. Get it lubricated, your finger lubricated, because the tissue inside your body is more delicate than the tissue outside of your body. So you want a well-lubricated finger. You want to push that suppository in very far as your finger will go. And if you have a little baby, you might need to use your pinky if you have a little child. But for an adult, teenage sized person, you need to get that suppository in there as far as you can possibly get it in. And then when you have that done, it needs to go up against the wall of the bowel. So if your bowel is full of stool, you are going to need to take some of that stool out, manually remove it to put that suppository in. And then wait till the suppository dissolves, and then do the digital stimulation. Or you can use a mini enema. They're only 5 milliliters of fluid. But we're going to talk about that in a minute. And then do your digital stimulation very gently, not to the external sphincter. So some people only do the rectum that opens to the outside of the body, and they're stimulating that. That's not going to do anything to stimulate your bowel. You have to put your finger in as far as you can and try to find that internal sphincter. That's the one that has to be relaxed to get the stool to come out. So, and you have to do it very, very slow, because if you get in there and you're whipping it around, you're just making that spasm in your sphincter and in your bowel tense up, and it's going to make the stool impossible to come out until that spasm gets released. And that's usually why bowel programs take so long. It's because it's too quick. You're not doing deep enough into the bowel. Okay, now if you have the lower kind, the atonal, the one where there's no spasm, you're going to need to just go in and manually with your finger remove the stool. Now, some people do it once a day. Some people can go every other day. But there's no tone in that sphincter, that internal sphincter. So it's just going to roll right out when the stool becomes present. Some people will check it every time they toilet. Now, is that a little excess? Well, if it makes you comfortable and it works for you, that's fine. Do it. Okay. Another thing that we don't often talk about in the bowel program is your own self-experimentation. And the reason why we don't talk about this is because if I say, well, try this or try that, people will go home and say, well, Nurse Linda said to try these things, but Nurse Linda does not know you and your special needs. So always talk with your healthcare professional about these things. If you're constantly having to mushy a stool and you were put on Senna and Colace, maybe you don't need one of those drugs. Maybe you could talk to your health professional about stopping one of those drugs, not stopping both of them together because you'll never know which one worked, or maybe that's too much to stop and you become constipated. So think about stopping one of those. If your suppository is not working, there's two different kinds of suppository. Well, there's three different kinds of suppositories that are used. One is a Ducalox. It's Bisacodal is the stimulant that's in there. And the Ducalox suppository has a vegetable coating. So it takes a few more minutes for body heat is what makes the suppository dissolve. That's why it has to go up against the bowel wall, because if it's in the middle of stool, there's not enough body heat to melt the suppository. So it has to be up against the bowel wall, and then it will melt there. Some people like to put the suppository in, wait 10 or 15 minutes, and then transfer onto the toilet because then they have less toilet time. So the Ducalox suppository allows that because you're waiting for that vegetable coating to dissolve, and then the suppository will dissolve. There's another suppository called the Magic Bullet, and I know there was a question from one of our readers about that. And the Magic Bullet does not have any kind of coating on it. So the minute you put that in next to the bowel wall, it will start dissolving. It's still bisacodal, but it will start dissolving quicker. So when people use that one, they usually want to be on the toilet. But maybe they have still, by the time it dissolves, maybe they have 5 or 10 minutes. So they will do that. Sitting up is an important piece to this puzzle as well, gravity. Now, the third type of suppository is glycerin. And that's a more gentle suppository. It does not work with the average adult, but it's good for infants and it's good for elderly people that don't need that much stimulation. Now, there are some people that are just more, I don't know, more gentle in their body functions. And sometimes the glycerin will work for them. Sometimes people can eliminate the suppository and just do the digital stimulation. Back in the day, we used to call it bowel training instead of a bowel program. What we were doing is train the bowel to work precisely at this time every day. And so the goal was eventually to get off any kind of suppository or mini enema and just do digital stimulation, even if you have the higher level type of injury. And so the bowel would just be trained to work at that time of day. Somehow we got fancy and we started calling it the bowel program because it involves so much more with diet and exercise and all these different things. So we wanted to encompass the wholeness of the program in there. So that's kind of how that changed. So those are kind of some of the things that will help with the bowel program. So there's some questions about the bowel program in here, but there's a lot of questions today. So I want to get talking about some of these questions. Now, today is bowel day, but you're absolutely welcome to ask any question at any time. And so what I want to do is I want to add in, first question is that somebody wrote in, they're having post-polio syndrome. So, years ago, there was the big polio epidemic and it caused a lot of paralysis and it was really tragic. And it was from a virus, and it's kind of, the symptoms and the results are not parallel, but it's kind of makes me think of the COVID virus that we have now. We're in a COVID pandemic and it's still out there and people are still getting it. So You want to take all your prevention measures to be sure that you don't. But people who had the polio in years gone by, that recovered, are finding that if they left with some symptoms, like maybe their legs didn't work as well, or one leg didn't work as well, or they maybe some breathing problems, or if they had some symptoms from their polio, or if their polio symptoms resolve, they're finding as they age that some of those symptoms are kind of returning. It's not that the disease itself is returning, but those muscles and nerves that were injured by the polio were weakened and other ones compensated. And now that, as you get older and, you maybe not as mobile as you used to be, or just as we age, they're finding that that weakness is returning. And so how that will be with the COVID, we don't know. But anyway, so post polio, it conjures up a lot of people don't know, a lot of people think, oh, polio is gone. We eradicated that because everybody got the vaccination, so it's gone. No, the virus is still out there. We don't have much of it in the United States, but it pops up in different places at different times because the virus is still out there. Just people don't get it because they've been vaccinated and we have the herd immunity. And there's a lot of questions about that, but people just don't get it as much as they used to. Post-polio is not contagious in that way. It's a result of issues that occurred from before that are now kind of resurfacing. How to locate rehabilitation services that optimize success. There are a variety of ways to do that. So, there's different levels of rehabilitation. There's rehabilitation facilities that specialize in spinal cord injury and brain injury. So neurological problems, they're great at those places. They're all over the country. We have the government model systems that has hospitals around the country that specialize in brain injury and spinal cord injury. Sometimes they do both. But I'm thinking of some of the major centers like Craig in Denver and Shepherd in Atlanta. And then there's Baylor in Texas is a big rehabilitation center. The Shirley Ryan in Chicago. In Seattle, there's the University of Washington has a super program. There's some of these super programs out there. Now, maybe you can't travel to that place to take advantage of that, but they have a lot of their information online. So you can get a lot of helpful information about what they're doing and different therapies and all kinds of information, as well as at the Christopher and Dana Reeve Paralysis Center. If you go on their website, they have information just about everything. Booklets, it's all downloadable, it's all free to you. So there's a lot of places to get information just in general. Then you can take it to your local rehabilitation facility and use some of this information to see if this is the right thing for you and talk to your healthcare professional. I mentioned Baylor, and I was at conference last week at the ASCIP conference, the Academy of Spinal Cord Injury Professionals, and I met a nurse from Baylor, so I want to give a shout out to her. So hello, I know who you are. And so I'm not going to say names because, we're online, and I guess, that is a poor thing to do without a person's permission. So you know who you are. And so it was very pleasant meeting you. So thank you for that. So if you want to optimize success, look at what they're doing in some of these other places. They're very quick to share that information. And then you'll see on the website, there's all kinds of information that has popped up. And my question box did not pop up until just now. So I want to just check real quickly and see if there's any questions that are in the immediate. Okay, all due respect to bowel programs. Yeah, because that's the thing. Okay, so there's some question about bowel control. So we've kind of talked about that, and there's more information. You can click on that link that will give you more information about bowel programs. Catheterization using the indwelling versus self-catheterization. Well, doing the self-catheterization program has a huge difference in infection rates. They're much, much lower doing self-catheterization. So that's why we always go to that versus indwelling catheters. Now, there are some people that have difficulty. Maybe their spasms or their tone is so out of control that they can't spread their legs to do the catheterization. A lot of times females will opt for the intermittent catheterization because it's so difficult, or for the indwelling catheter because it's so difficult to do if like you're going to work and you're trying to catheterize in an accessible bathroom that's not really accessible. So there's a lot of issues. Sometimes men with retracted penises will opt for the indwelling catheter because of the difficulty. Sometimes people who have hand function, if they don't have hand dysfunction, if they don't have somebody who can do the intermittent catheterization for them, or if they can't wear external catheters. So we always opt for the self-catheterization because of the infection risk, and also it mimics the normal pattern of the bladder. So your bladder is allowed to fill, so that bladder muscle, it's a muscle, it will stretch. It's smooth muscle, it will stretch as the urine collects in it, and then when you catheterize, it contracts. So it keeps that bladder functioning. And it's always important to keep the bowel and the bladder functioning in the usual fashion as long as you can, because once it stops doing that, you have trouble. So if you have an indwelling catheter, the urine is just constantly being removed. So the bladder always stays contracted. Then if you try to go without the catheter, it's hard to get that bladder to start stretching. It can be done, but it can be sometimes an arduous process to re-stretch out and regain that function. Now, with all the treatments that are coming up, you really want to keep your bowel and bladder functioning in the most usual fashion, because it's going to be important in some of the new treatments that are being developed. So a person has written in about being in a developing country where there's not a lot of resources. And I say, if you have the internet, which you do, because you've written to me here through the internet. So look at the Reeve Foundation on all the information that they have. Take it to your healthcare professional there. Some of the products you can buy in other countries, even without a medical prescription. So, but working with somebody who has an idea about healthcare will help. You know, you can get catheters from different countries. You know, in the United States, we have to have a prescription, but in other countries, you can buy a catheter. So you can get bowel program equipment, you can get wheelchair equipment. It's hard to find the funding for that, I realize, but there are ways that you can access different things from other countries, especially the knowledge. So having the knowledge about what you need to do and how to care for yourself is going to be a key place to start. Somebody's written in about people with depression because they have so many care things that they have to think about, and it becomes oppressive. And I know that it does. Doing a bowel program at a certain time every day, man, oh man, it can become oppressive. I always have to be available at this time because, again, you're training that bowel not to evacuate except for when you want it to. So you're controlling the situation. Catheterizing and doing the catheterization process and monitoring your fluids and, doing your pressure releases. The fortunate thing about all of these things is it becomes habit after a while. So you kind of people get into routines after a while. You kind of wake up at the same time every morning, you kind of have breakfast at the same time, to catheterize, at this time. So routine helps a lot. It's really hard when you're first starting out, and literally every second of your day is some kind of management because it takes so long to do everything in the beginning. But as you get better at it and as you get more comfortable with it, you really learn how to do things more quickly. So most people, it takes about 5 to 10 minutes to catheterize, depending on their setup. Some people's home's not as set up as easy as other people's, And there are challenges all along the way, but if you get yourself a space organized in the bathroom, or if you have a table that you can cover your things with, if you don't, it doesn't have to be out in the open, it could be in your bedroom, and you can catheterize and, wash your hands and, have some kind of washing ability to clean your hands at your space. It can be a little more tricky at work, but some people will work with you at work. If you need privacy, sometimes they'll allow you, I have some special needs. You don't have to explain again to everybody what's going on, but may I hang a note on the door so that I can do what I need to do to toilet without somebody else coming in, or if the stall situation and your wheelchair doesn't fit in the stall. Now with government compliance, they have to, correct that, but there are ways that people can get around doing that, which is, why would you want to do that? I mean, just seems ridiculous to me. But all that kind of thing, is very helpful to get over it. When you're depressed over things that are happening like in your life like this, it's called a situational depression. Remove the situation, remove having to do all this stuff, you won't be depressed about it anymore. If you've identified that this is the thing that is causing me trouble, if you remove that thing from your life, but you can't remove that because you have to live. And these are things that you need to do to live. But it does get easier. And if you talk to some peers, you can talk to some peers in the peer mentoring program through the Reeve Foundation. There might be some people in your community that do peer mentoring. And if you talk to somebody who's in the same situation, they can give you a lot of tips and time savers, and they can really help you. Yeah, it's a problem. It's annoying to have to catheterize. It's annoying to have to do the bowel program. But if I don't get to see tomorrow. If I don't do these things, I don't get to see my kids grow up. I don't get to hear who's going to win the World Series. People have things that they want to do and accomplish in life. And those are the things that you need to focus on when you're thinking about these things. Now, it doesn't magically disappear. You might want to talk to a counselor and get some medicine or some therapy to help you deal with all these things. It's a lot of stuff to deal with. It's not like people are going to take this big of a change in their life and be like, oh, okay. I mean, there are a few people do, but there are few and far between. Okay, so what's the name of the suppository? It's a Dulcolax, Dulcolax. I hope I've spelled it correctly. Not good with the better reading it. That has the outer vegetable coating, and the one that does not have it is literally called the magic bullet. Was invented by somebody who has a spinal cord injury, and their bowel program was taking too long for that suppository to melt, so he created this new project and he called it what he liked it. It's the magic bullet. Okay, so now here's a question talking about hope for the future. There's a research that's going on by Samuel Stupp, S-T-U-P-P, and it's called the dancing molecules. He calls it the dancing molecules. He's at Northwestern University, which is in Chicago, Illinois. And he's working on an injection into the spine that will help repair the spine at a molecular level. And he's having some very good results. Now, I must point out, this is only being done in rats right now. And if you look at a lot of the promotional information, it sounds like it's coming next week. And I don't think that it'll be coming next week, but it's very successful in the laboratory in rats. Now, so what they do is they've got some rats, and if you go to Northwestern Medicine, I've got it pulled up on my computer here because it's just so fabulous. It really is a fabulous project, and I always want people to move with caution. So this is a fabulous project done by well-known, highly educated, very ethical and legitimate researchers. So this is a great project. Okay, so what they're doing is sometimes experiments are done with rats, and they're given a spinal cord injury. It's done in the laboratory, it's humanely done, and I mean, they're anesthetized and their body temperature is controlled. They're, it's very well controlled. And so they're giving these rats spinal cord injury, and it's done with a weight that's put on their spinal cord, and so that each rat has the exact same location of the injury, the exact level, the exact weight. They know exactly what time the injury occurred. It's all very well controlled. Even still, some rats without any kind of treatment will recover differently than other rats in the same experiment, just like people do. So it's kind of really, there's a lot of parallels. Okay, so what they're doing is they're injecting this substance, and it works on the molecules inside. We know that there's a lot of things that goes on at the molecular level in the neural system. And so they're kind of capturing what's happening there. And so he's got pictures of his rats, which is always kind of fun to see, pardon me, how well they're doing. So rats, when they walk normally, their tail never touches the ground. The whole length of the rat's tail will be above the ground. It never touches the ground. So they show a rat that's paralyzed. He's not using his back legs, and his tail's completely dragging along the ground. So he's a paraplegic rat. Okay, then they show one after they've given the dancing molecules injection. And what the rat does is he's able to use his hind legs a little bit, not like he could before he was injured, but he can use his hind legs a little bit. And his tail looks like it's up off the ground, maybe for like about an inch, inch and a half. And a rat's tail's about, I'm going to say 3 to 4 inches long. And so it's seemingly a very positive outcome. Now, real researchers like these people who are really into research and very ethical, never pick the rat that's the worst one, and they never pick the rat that's the best one. They pick the most average rat to show, both in the one that's been recently injured and both in the one that's had the treatment. So I would assume that that's what these people have done. So kudos to them. This is a great experiment. And then after they inject the substance, it does what it needs to do to the molecules inside your body. And then the injection molecules are eventually used up and removed as waste from your body. So very, very cool. Now, the information about it says we're going to go straight to the FDA with this. Now, there's a lot of information that the FDA requires from the bench or the laboratory science over to people. And so that will be looked at very carefully to the FDA. There are some ways that you can move this straight from the bench to it has to be validated by several different laboratories, independent of each other, to say, yes, this is not an artifact of this one laboratory. But there is a way for people who have no alternative treatment, like spinal cord injury. There is a way that the FDA can do allow small experiments on people. So we'll have to see if that happens. So we're not in the position where this is going to be coming out next week, next month, or even maybe by the end of the year. It's going to be some time, but this is something that we have to watch carefully, because this is going to be a very exciting and potentially very beneficial study, but we don't know that yet. We have to see what happens in people. Sometimes when you inject things into people, it should go to the place where it's supposed to work, but it could attach to something else. There's all kinds of things. Will it grow too many nerves? Will it grow pain nerves, and people have chronic pain? There's all kinds of things to think about this, and I'm sure that these people have. This is just Nurse Linda talking about be cautious, and so we have to see. So when is this going to actually happen? I have no idea, but we'll keep following it, and we'll hear more and more about it. And it is very exciting, and it is very hopeful. So next question. So anyway, I get real excited about this stuff. Okay, so here's a person that says they can't spend more than 2 hours in their power chair without pain in their bottom and their legs. So this is something that's happening is probably some neuropathic pain, and there are treatments for neuropathic pain. There are medications that you can do. Check your seating cushion to make sure that you're on one that's helping with your pain control. So people are given cushions, medical grade cushion, it has to be. You can't use any other kind of cushioning material. People say, well, that's foam, and I can get foam at the craft store, but the foam is constructed differently. It's closed cell versus open cell. You've got to have medical grade equipment. That's all there is to it. No pillows, medical grade equipment. Now there's some, once you get past the standard cushions, there's some that have robotics within the cushion that will relieve pressure, like in 4 corners. There are some like the Rojo cushion that has these finger projections that you sit on. It's an air cushion with these finger projections, and your bony prominences go between those finger projections, so it helps with pressure injuries. So there might be something, some kind of cushion that might help with your pain. There might be some, if it's in the anal region, perianal, there might be some topical anesthetic that might help you. Talk to your healthcare professional about all of these things, because you know, there's no need to have that. It says wearing knee-high support. I mean, you might need thigh-high support, and I'm sure that's the stockings. And he says he's tried topical medications as well as medications. Nothing helps. Any ideas? It might be time to move on to some kind of an injection, a Botox injection that will help with that pain, or if there's spasming involved that maybe can't be seen, but maybe there could be some spasming in there. You know, just keep pursuing that. But I think looking for a higher level cushion, and right now there's a bill going through the government. You can check on the Reeve Foundation. They have a policy section, and you can send in your name to your representatives and your senators to pass this bill to help fund particular kinds of seating. So that's something to think about, as if you want to work on a higher level for the community in general. It says, please explain the bullet for the bowel program. And we talked about the magic bullet. It says, my doctor provided enemies, which I thought was a bullet. Well, enemies works a little bit different. It stimulates the nerves in your bowel, and it doesn't have the bisacodyl formulation in it. So it's a little more gentle on the bowel tissue itself. But it generally works a bit quicker. It comes in a tube like about this long. It's literally 5 milliliters. So if you think about a medicine cup, it's like just barely the bottom of the medicine cup of fluid. And there's a thing that you can screw on it. So you insert it. Now you can't insert the enemies into bowel. It won't work. It's got to be against the bowel wall. So if there's bowel in there, you're going to have, if there's stool in there, did I say bowel? You can't squirt it into stool. So if there's stool in the bowel, you have to remove the stool so that it can go up against the bowel wall. And this stimulates the nerves to work. And some people like it much better than the suppositories. It seems easier to work in the installation, and it seems to work much quicker. But then again, you know, it's different for everyone. So there's a couple of different kinds of these mini enemas. And again, they're mini, they only work in the lower bowel. They're not going to flush out your whole bowel system. So there's enemies, and then there's Theravac. Theravac is getting hard to find. There are some people who still have access to it, and I'm not quite sure how, but those are the ones. You might have been on Theravac before, or you know, you may have heard of those. Where do I find a sexual surrogate living nearby? That's an interesting question. And I've had people ask about that. And I'm happy you asked about it because some people don't want to talk about sexual issues, but it's very important. And so I am going to assume that this is a person who has some kind of neurological injury, and they want to do some experimentation, maybe with positioning or maybe figuring out their triggers for sexual function. There's all kinds of ways. So talk to your healthcare professional because you don't want to, you want to get somebody who is a professional person about this. Your state might have a licensing bureau. If you call your state's Department of Licensure, there might be a license required for a sexual surrogate. But I would check with my healthcare professional. I would check with the state. If you're involved with a social worker in any way, I would check. Maybe you might call the number on the back of your healthcare card. I've not heard of sexual surrogacy being funded by insurance. So I doubt that they would have any suggestions, but they might have information. The case manager might have information from other clients or something. It depends on how much you want to expose this information to other people. Because not everybody is going to be understanding or open about it. They're going to be like, what are you talking about? So, just think about talking to your healthcare professional. They might know of somebody, or if they don't know of somebody, they will know how to find somebody in your particular area. So, that's what they're there for. So use them. They might put their nurse on it, or, there's a variety of ways to find people that do those. So you're looking for a sexual surrogate who you might find it through your psychologist or your counselor. They're usually more in tune to that segment of the counseling therapeutic type population. So those are just some ways. I hope I've helped some people today. I hope I provided you with some information. I'd like to thank Chris and Tim and Julie for their help in putting together all of this today. It's been a good day. And if you have any further questions, if you would like to write in on the webpage, that would be just great. I can answer those questions for you as well. And I thank you very much for joining us today. Hope to see you next month.